So the next, they've appeared. The next topic we're going to discuss, one that came up earlier, is decreased fetal movements. And as I said, fetal movements, I say an obstetrician's best friend, but also a midwife's best friend. So once again, Paul's going to be leading the discussion, and we've got Julie Wright, who's from Albury-Wodonga, and Nicola Ewan, who's actually Director of R&G at Bendigo Health Service. So thank you very much, and I'll leave it up to you. I've just got the pin here. Oh, sorry, move it on to the next one.
Have we got the next slide?
Yep.
So I had some feedback before that I didn't speak loudly enough. So usually I get told something different. So if you can't hear me at the back, please let me know.
Do you want to come up to the microphone as
Oh,
well?
I'll try that instead.
No, leave them both on.
Leave them both on.
It amplifies.
All right. Okay. So I worked on this one with Nicola and Julie, and I'm sure Nicola would agree with me that Julie was simply amazing in the development of this one. She just did all the hard work, and we just were astonished. So thank you very much, Julie. And there was unanimous agreement that this was a really important topic for us to address, and we also found out there was probably quite a lot of variation in how this was being approached, as well as the usual old myths about movements decreasing near term or to go and drink or eat something. So we really wanted to make this evidence-based and as simple and as practical as possible. So in this pathway is information about decreased movements and poor obstetric outcomes, and a focus on prompt assessment and review of a woman presenting with decreased movements. Information for all women that's presented early in the pregnancy and then later in the pregnancy, and links to the PSAN's information for women, which is available in 8 languages. We've included a flowchart, and there were many flow charts. We tried to amalgamate the best of all of those and keep it as simple as possible. And suitable for the whole of the state and the different health services. And we've suggested also some standards that you may be interested in auditing. So, yeah, I just wondered if anyone would like to ask any questions to start with, or whether our panel would like to start with some questions or observations.
I'll start off and ask you
Okay.
one. In your template,
Yes.
you've actually said that anybody who rings up should be asked to come in and have a CTG within 2 hours. How's that going to happen? Is that going to happen?
Well, I could say why we're doing that is because there probably was sometimes when it's very busy, people might unconsciously try and say, oh, just go away and eat something, think about it, come back later, not picking up on the importance of it. So we wanted to make it a focus. How is it going to happen? That is difficult. I think in some regional centres that could be very challenging indeed. Also, whether there's anyone available who can interpret the CTG as well. I don't think, correct me if I'm wrong, we gave any suggestions on how that could be achieved.
No, we didn't, but I think it is worth, there was a lot of debate considering regional and rural when it came to this, with both Julie and I working in regional hospitals, that this was a very heavily debated between the three of us to ensure that the guidance that we were suggesting is applicable across the majority of maternity services as far as guidance, and we keep coming back to that word, as far as guidance can be provided.
And I think, it probably is up to each individual health service to find something that works. I mean, we should look at it from a quality improvement type approach. I remember a case, again, in Cairns, where late on a Friday afternoon, somebody faxed down a CTG from a regional hospital, which was dreadful, but it was after 5 p.m, so nobody looked at it. There was no feedback that it had not been looked at or received. And by Monday morning, of course, that baby was dead. So I think for smaller, more regional health services, I think there's a number of approaches. I think I'd be looking at the level and capability of FSET qualifications and interpretations of the CTG, where a woman can go to have the CTG. If the CTG can be performed, then getting it reviewed by somebody who knows how to interpret it. That may involve referral to a larger hospital. but closing that feedback loop is really important in that circumstance.
Great. And I guess the other thing is, in fact, and that's a wonderful illustration of something being sent on a fax machine, where in fact hospitals are the only places in the world that still use fax machines, and in fact nobody knowing it's there. So in fact, making sure that in your protocols that you have, that if you're sending a fax machine, you ring somebody in the place to which you're sending and say, this is coming and this is why it's coming. A question? Just push the button on the microphone.
Deborah Beryl from Albury-Wodonga Health. My question relates to the use of telemedicine and telehealth. I've got probably a recent extensive history of working in the rural and remote valleys of Victoria. I also live in one by definition. And I know that a number of the smaller rural health services have devoted a lot of time and money and expertise into getting the telemedicine, telehealth working. Is there a role for those of us in the larger centres to be able to receive some of that, as well as getting the facts about with the CTG on it? There can be a face-to-face consult with that woman.
Yeah, so
thank you.
That's possible, and there are computerised fetal monitoring systems. We've just got one at the Northern, so I can look at it. I could look at it from here if I wanted to. And we've connected up our outlying smaller. We've got two other services outside of Northern Hospital, and I can look at those. So that could, if there were complementary systems, our enormous component from Kilmore, we're getting the same system, and we will at Northern be able to look in a hub and spoke model. So I'll be able to look at Kilmore's CTGs in a regional setting. That would involve a lot of organisation. Another thing that's happened is just with FaceTime, as simple as that, I've had the registrars hold it up to me and I can see it while it's happening. In terms of telemedicine involving the actual patient in that discussion, I haven't, in that setting of a CTG interpretation, I haven't had that, but that could easily occur.
Yeah, look, I mean, I think they're the things that really, in fact, if you're in a small regional centre, it'd be sort of very prudent to actually go back and work out to what centre you're sent. We've been getting CTGs, our fetal monitoring unit, for 15 years, a long, long time, longer than that, for a long time, and they're faxed and now they're often electronically sent through. And so, in fact, I think that would be a huge gain for some places, because you're not always going to have somebody there who can read the CTG, and if you haven't got somebody who can read the CTG, but there's no point doing the CTG. And whether or not FaceTime would add to that, when you stop and think about how our registrars consult us, they'll tell us the story and then they'll show us a CTG. So it depends, I guess, who's the frontline person in the consultation. I would think just having a system whereby you can get the CTG reviewed is going to be so much value add. I'd actually probably be inclined to sort of, focus on that initially. And so you're telling me we shouldn't be telling women to have iced water?
Yes.
No. It's okay if he's got that message. He used to always do my head in, drink iced water. Can you tell me how a block of ice in your tummy can warm up whatever it is and tell the baby it's cold out here when in fact it's not cold out there, and make it kick? I think it's just called that association, but it's something that's well and truly out there, so we've got to get rid of that myth. So other questions about this reduced fetal movements? I think the most important thing is just to keep saying to women, is your baby moving well? Your baby should keep moving well. The baby shouldn't slow down towards term. And you say it again and again and again. It's just part of the thing that you put, we often put fetal movements tick, but do you actually say to the woman something about the fetal movements, or we just tick the little box? Because little boxes can be a real problem, really, because you tick them and then you don't think about it. Yep. Just turn the button to go green.
Julianne Barclay from the ANMF. I'm just wondering if there's a public education campaign to go along with this new guideline, because I think it's going to have great impact on communities everywhere.
I'm not sure that's our role. It's a really good point, and I'm not sure how we could achieve that, Chris.
No, I think one of the things that we have done in the past is, have regional meetings and we'd like to really, maybe start doing those again. Some of those we've been to, I think they've been quite worthwhile. There's a few heads nodding. And so it is a way that we can put these things out there. And I know I've spoken a number of times on reduced movements and growth restriction. So, yes, we would very much like you people to go back. We'll try in our newsletters to emphasise they're out there. And I know it's something that VMA are very keen for us to do. So I guess our energies have gone into getting it off the ground. But the other thing is that Felicity's done is we have an audit tool that will go with all of these new guidelines. That you won't be expected to use the whole audit tool because some of them are quite detailed of a lot of areas. Maybe pick a part of it that'll make it easy to audit things, and that will help. But yes, the more we can get it out there, the better it is, because the idea is just quickly accessible, and particularly for smaller centres, if you suddenly have a problem, you can look and see, well, what do you do? And that's the whole idea of it. You don't have to go through. And also the other thing is, let's face it, could you tell me the value in 49 health services writing protocols? Hello. All we do is just take the evidence, we put it together, and it's a little bit here because Joe blogs like this and somebody doesn't like that. So really, if we can reduce that time and effort put into that, it'd be very valuable. Mightn't all be what you like, for sure. You can have local variations, but the idea is to reduce variations, so we'd prefer you to use it as is, realising that people aren't all the same. They're not all cookie-cutter people, so sometimes you have to make modifications. Other questions? Yep. Can you just go to the microphone, please? Yours has got lost, has it? Oh, you've got it.
Joyce.
Just push the button so it goes green. Just push it and then let go. Yeah,
now green. Have you found there's been a really big increase in CDGs, girls coming in for reduced movements? We certainly have at our hospital a huge rate.
Actually, I'll let Chris talk, but I can talk from Albury-Wodonga Health's perspective. Absolutely. We've seen a significant increase, probably in the order of 10 to 20%. We're just seeing this consistent increase month on month. So I think there's several things. It's the awareness. I think people are really, there were times when you might say several years ago about, lie down on the couch, ring us back in an hour if the baby hasn't moved. We've moved right away from that. So we do have women coming in. And there's a couple of points just before Chris makes a comment. We have also moved to providing the PSATS information brochure, which is available in 9 languages, as well as there's one for Aboriginal women to women at 28 weeks. So we're one of the few health services in the state that doesn't have a public antenatal clinic. We have midwife care program and GP obstetrician-led care, but it's been, Michael Permazol at our regional meeting has certainly promoted providing that information at 28 weeks. So it will go to all the clinics, the doctors' clinics will hand it out at midwife care at 28 weeks. I suggested sending it out in the first trimester when they'd call to do their booking in. He said, you can do that, but do it again at 28 weeks because that's the, important time. And I think with your question, not only the increasing surveillance and women presenting, along with that comes resources, and that's a huge challenge.
Well, I'm finding a lot of women are ringing up saying my baby hasn't moved. And they're the ones who are driving it, not us telling them. They're ringing up because it hasn't moved for a few hours.
And look, I think, the reality is when we do things like this, and I can remember a few years ago there was a big push on fetal movements and everybody came up and then it settles back down to a certain sort of equilibrium. But on the other hand, if in the process we stop babies dying, that must be a good thing. And I always think one sort of figure that's given of the babies who have stillbirths, 50% of those women have presented twice with reduced movement. So it's not an inconsequential sort of notice that women have. And, it's and sometimes women, they're busy and they don't notice, and they'll sometimes ring back and say, look, it's kicking now, I'm happy, that's fine. But, that's something we have to do as part of providing good antenatal care. So, yes, you need to look at it. If it needs more resources, of course, there's so many resources, aren't there? But looking at how you can do things efficiently, I think that's the other thing. Yep.
I've got a question how you manage someone with mental health problems such as borderline personality and stuff, because we've got a client currently who's here every second day for a CTG with decreased fetal movements, and we were inviting her in on each occasion, but it's actually more about her mental health and her, well, you know, it's like the boy that cried wolf. We have to take it seriously, but it's repeated.
You want to answer?
I'll just make a comment that I'm well aware of some patients similar to that. They're a very at-risk group for lots of reasons. They tend to over-engage and then under-engage with care. I think that there's two sides to it. The first is you're exactly right. There is no boy who cried wolf. What this guideline says and the support that we're giving is that if someone presents with decreased movements, they need a CTG, regardless of when they last had one done. The second thing is really around sort of the mental health support for women that do have mental health issues during pregnancy and how that can impact on how they engage and receive care. And I think that's probably a separate conversation, but I absolutely understand the complexity.
Do you want to make a comment?
No, I was not particularly on that point, but just going back to the guideline talks about women presenting within 2 hours, and then once they're there in the service, they should have their monitoring done within the 2 hours. And I think Nicola picked up on it earlier, but, part of that rationale was, as Nicola said, around thinking of rural, regional as well as tertiary. You can't just say 30 minutes because some people might live 10 minutes from the hospital. I think of the likes of Corrion. I'm sure there's people down Western District or whatever. They could be an hour and a half's drive from their nearest health service, or they go to the local health service, but they may not have someone on duty that can perform the CTG. So I think there are another number of factors, and Deb Birrell and I, Deb having worked before she came back to Albury-Wodonga Health, across Alpine Health, what are the plans and the relationships you have in place with the regionals, with the rurals, but, the rurals in turn with your regionals. Sounds like there's something great happening with Kilmore and Northern where they can actually visualise the CTG. But, a woman might drive to a local hospital. There's no one there to put on the CTG. So what's the plan? What's the backup? Alpine had it that they would actually call one of the doctors would go in and put it on if there was no midwife, which was often the case, and then so the doctor could interpret it. So it might be that someone can put it on, but what level of understanding do they have? I know we're all expected these days to do fetal surveillance, but it might be a young graduate or someone with less experience. So I think it's really important to ensure there's relationships and a strategy in place, and closing that loop and not sitting on the fax machine. So I've been trying to catch up with someone from Yarrawonga, but talking about that relationship, because I think they certainly have had some concerns about women presenting, and some hospitals I think are concerned about women that aren't booked there that might turn up. If they don't have someone on, they might be driving an hour down the road to have a CTG. So lots of things to think about.
We might have time, I think, just for one more. We've had the 5-minute warning about 5 minutes ago.
Just one comment as well is these guidelines sort of give the health workers a little bit of oomph to be able to go to their administrators to be able to say, look, this is a guideline, this is what people are advocating, this is evidence-based. So really we should be taking the advice and putting more resources into these organisations that maybe haven't got someone there that can read a CTG or put a CTG on. You've now got the evidence to say this is what we should be doing, this is where we need to direct some of our resources. So I think that's a great thing about these guidelines.
And that's obviously what we want you to do. The more people engage, that'll become the standard, if you like. And then, in fact, we hope that'll improve outcomes. Just something about it. If we save 10 babies here, that'd be wonderful. Just the 10 families and lots of maternity workers who don't go through that grief. So, look, we're going to stop now for lunch. And we'll come back here at 1:45. So lunch is here. You're welcome.